Hi, I'm Missy. Today I'm going to talk about a needle tracheostomy. So the indication for a needle tracheostomy is a surgical airway in a child who's less than 8 years old. Now in an adult, we would do an open surgical crich using the scalpel finger bougie technique going through the cricothyroid membrane. In children, the cricothyroid membrane is much smaller relatively. So instead of doing a cricothyrotomy, we're going to do a needle tracheostomy. The goal is to insert a needle between any of the tracheal rings, performing a needle tracheostomy. The reason we do a needle procedure on children instead of an open procedure is their anatomy is relatively much smaller. The cricothyroid membrane is too small. We're not going to be able to palpate that. So the landmarks for children are much smaller, and we're going to use a needle instead of an open procedure. Let's overview some of the equipment that we're going to need to perform this procedure. So generally, any sort of needle that does not have a safety catheter on it. So IV catheters are not going to work for this procedure. This is because we need a needle that's a solid bore that we can hook up to a syringe, because we're going to draw back on the syringe as we're inserting the needle. You can use any sort of needle that you would use for needle decompression, but keep in mind those needles are a little bit longer, so be careful not to push them right mainstem in a young child. The other equipment that we need is the equipment to deliver the oxygen after the procedure has taken place. There's two ways to do this. One, you can deliver it through an infant BVM. The other is to do jet insufflation. So if we're using an infant BVM, we need a size 3.5 ET tube connector. So just pull this off of a 3.5 tube, which will hook to your BVM, and then this will hook directly to the needle hub. Now, if we're using this device to oxygenate afterwards, we're slowly squeezing the bag and then allowing plenty of time for exhalation. Another way to ventilate a child after a tracheostomy is to perform jet insufflation. Now, many agencies may have pre-made kits, but I'll show you a way to make one with the equipment that you have. It's important that you have this set up before you are performing the procedure because you don't want to be searching for this equipment when you're in the middle of the procedure. So I'm still going to use that same 3.5 ET tube connector, but this is a time where a meconium aspirator actually is useful. So that meconium aspirator will go right on the hub of the ET tube connector. And then you can take the suction, and instead of hooking it to suction, hook the suction to an oxygen tank. Now when I want to deliver oxygen, I cover the suction cap, and this delivers oxygen, and then when it's time to exhale, I can uncover, allowing the child to exhale fully. So this is a very easy, low-tech way to make your own jet insufflation system. Now remember, the goal of this procedure is oxygenation, not ventilation. So we're not going to attach an end tidal, but we're going to just continue to oxygenate until we can keep the sats above 90. You're not going to get enough airflow to get good ventilation in these cases. Now let's do a close-up of some of the equipment that we may use. There are a variety of sizes of needles. I'm going to choose a small needle because I'm going to simulate this is in an infant. But remember, you can use any of your needle decompression needles to perform the same skill. So take the needle and attach it to your saline, and just make sure when you pull back that you get some bubbles. So this time I'm going to take my non-dominant hand towards the patient's feet. I'm going to palpate the trachea in the case of a child, find a space between the rings, and slowly move down, inserting the catheter. Once I get through the skin, I'm going to pull back until I get bubbles. Once I have bubbles, I'll advance the catheter, remove the needle, put it in a sharps container, and then add my jet insufflation. Now I'm ready to cover, to oxygenate, and uncover to allow time for exhalation. Another option aside from jet insufflation is to just use an infant BVM to oxygenate the patient. You can attach the BVM right to that 3.5 ET tube connector, squeeze the bag to oxygenate the patient, but you may need to move the BVM to allow time for exhalation. So you can see this is a little more cumbersome, but it will definitely get the job done to oxygenate the patient.